Hi, everybody. Welcome again to DermaSpark Academy. Today, we're going to talk about blood veins and vascular lesions and how we can treat it with the alpha system. Just before I hand over to Doron, I just wanted to remind you guys what you probably saw in the email from yesterday. My alphalaser.ca is already in the air, and all of you guys are listed on the location list. So please check it out and make sure that your name, address, everything is spelled correctly, because as we always do, we are going to push a lot of traffic to this website via Facebook and Instagram and Google and whatnot. And we want customers to do, clients to find you guys. This is our way to help you with marketing and to push business to you. So check it out. And Doron, are you ready?
Yes, I am. Can you hear me?
Yes, we can hear you loud and clear.
Perfect. Oh, just a moment. My video. I'll
Okay. Now we can also see you. You are so handsome.
Oh, thank you. You as well, Moshe.
Oh, you are younger. You have an advantage here. Yeah. Okay, go ahead.
Okay, thank you, Moshe, and hi, everyone. It's good to see you all back here for the third and last training session, Zoom training session that we are doing for the Alpha. Just to remind you, we began with the first session way back when. What was about the hair removal with the diode laser. We focused mainly on the diode laser. Then several weeks ago, we had a second session about training about how we can use the 3D IPL technology to treat pigmentary lesion. And today we are going to focus on vascular lesions. And this pretty much covers the main spectrum or the main array of treatments and applications that we have with the Alpha. We also have the acne handpiece, but this is maybe we will have a different Zoom training for specifically for the acne. But today we're going to focus on treatment of vascular lesions with the 3D IPL technology. So let's get started. What I want to do first, before we dive into the physiology of blood vessels and the anatomy of it and how the system works, I do want to have a few moments to quickly remind ourselves what is IPL and how IPL works. I know that we already saw these slides and you are familiar with those illustrations, but it's been a few weeks since we talked about it, and I just want to have a quick refresher to IPL. So we'll do it quickly. So IPL, intense pulse light, this is a light source that is comprised of a spectrum of wavelength, which means that this is polychromatic. As you can see here in the picture to the right, we have all the different wavelengths all the way from the blue light through the green, the yellow, the orange, the red, and the near infrared wavelength, which means that we are approximately in the range between 400 nanometers to 1200 nanometers. So IPL is polychromatic as opposed to a laser, which is, as you remember, this is monochromatic and it has only a single wavelength. IPL is polychromatic, and because it's polychromatic, it can target different chromophores in different layers of the skin, and we can use it for multiple applications. Now, two other important distinctions between IPL and laser is that IPL is incoherent, which means that the waves of the light travel in different frequencies and different waveforms, and they are also diverging, which means that they travel apart from each other as opposed to a laser where the beam is more collimated, the rays travel in parallel to each other. So these are the three main optical differences between IPL and laser. Another thing that we mentioned when we talk about the IPL is that different components of the IPL spectrum can penetrate into different depth in the skin. And generally speaking, the longer the wavelength, the deeper the penetration is going to be. So if we look here to the left, we see again the IPL spectrum and how different wavelength, different colors penetrate into the skin. The blue light penetrate almost never, doesn't penetrate into the skin, very superficial. It bounces back from the skin surface. But the red light and the near infrared light can penetrate as deep as 5 millimeters into the skin. And another thing that we said is that we rarely use the full spectrum of the IPL. We use different cutoff filters that allow us to eliminate parts of the spectrum that do not contribute to the clinical target or to the treatment that we are targeting. And we gave a few examples. We gave the example of the acne filter, the 430 nanometer, which is the only application, as far as I know, that we are using almost the entire spectrum of the IPL from 430 nanometers up to 1200 nanometers. And we do so because we want to include the blue light, the blue component that has more drastic impact on chromophores that are generated by the P. acne bacteria on the skin surface. But if we want to treat deeper lesions, for example, epidermal pigmentation or superficial capillaries, then we need to go a little bit deeper. We need to use a higher filter, and we are using the 530 nanometers for these types of applications that allow us to go deeper into the skin. However, if we do want to treat both vascular and pigmented lesions that are more deeply rooted beyond the level of the epidermis and the epidermal-dermal junction, more in the papillary region of the skin, then we need to select the 590 nanometers that allow us to go even deeper. And the 590, in addition to deeper vascular lesions, deeper pigmented lesions, can also allows us to treat fine vellus hair on the face. Okay, so these are the main applications of the 590 nanometer. And if for some reason you didn't get the diode laser and you do want to treat hair removal, then you can use the 650 nanometer that will leave you only with the red and near infrared components of the spectrum. And this is the part that penetrates the deepest, and it can reach the bottom of the hair follicles. Okay, so this is how we can use different filters or different handpieces to control the application of the IPL treatment. Another important thing that we said about the IPL is that it's not only about the theoretical depth of penetration of the different components of the spectrum, but this is also, we also need to look at the target chromophore and how well it absorbs the light that we are that we treat the skin with. Okay, so we need to see how deep the lesion is and what is the target chromophore and how this target chromophore can absorb the IPL spectrum. And again, we gave a few examples. In case of pigmentation, the target chromophore is melanin that accumulates in the epidermis or in the epidermal-dermal junction, which is relatively superficial. So we can use the 530 nanometer handpiece that also had a very good absorption by the melanin. So we are interested in how well this wavelength is absorbed by melanin. So we use the 530 nanometer, but if we want to treat vascular lesions that are more deeply rooted in the skin, of course, that now the target chromophore is not melanin, but is oxyhemoglobin, or the red blood cells of the blood. So we target the oxyhemoglobin, and we need to go a little bit deeper into the skin. And to that end, we are using the 590 nanometer, which you can see is located exactly here on this local peak in oxyhemoglobin absorption. So we will have somewhat less absorption by melanin, more absorption by oxyhemoglobin, and we will be able to penetrate a little deeper into the skin. So this is in the case of vascular lesions. And in the case of hair removal, again, we are interested in targeting, we are looking to target the melanin in the hair, which is more, which is deeper in the skin. So we have to use a longer wavelength to go deeper into the skin. So we are using the 650 nanometer that still has a good absorption by melanin, but you can see the drop in the absorption of the oxyhemoglobin. So more energy will be directed to the melanin rather than the oxyhemoglobin. Okay, so in a nutshell, to conclude this quick reminder to IPL, when we use IPL to treat vascular lesions, pigmented lesions, or even hair removal, we have to take into account the depth of the lesion and how well the target chromophore will absorb the wavelength that we are choosing to work with. Okay, these two parameters have to coincide. All right, and that concludes the quick recap to IPL. And now what we can do is to start talking about blood vessels and physiology of blood vessels and the anatomy and all this jazz, and generally speaking about the circulatory system of the body. And I want to talk in general terms first. I want to dedicate a few moments to talk about this slide, to talk about the systemic circulation in the body, because this is the backbone of any vascular lesion that is developing in the skin, and this is the backbone of the vascular lesions that we are treating with the IPL. So we might as well familiar ourselves with how blood flows in the body. So I would like to begin with diagram number 1 here. So all eyes on diagram number 1, ignore number 2 and number 3 for now. We will talk about them in a second. If you look here in picture number 1, well, and I'm sure that you already know that this is a common knowledge that there are 3 main types of blood vessels in the circulatory system, in the blood circulation, and these are the arteries, the veins, and the capillaries, right? And of course, that's the heart, that is the pump that flows the blood throughout the system. Now, the arteries, they carry oxygenated red blood cells and nutrients to organs and tissues all throughout the body, including the skin, of course. The veins bring back from the tissues and from the organs, they bring back carbon dioxide and waste, metabolic waste, back to the heart, to the lungs, and to filtration in the kidneys. And what connects between the veins and the arteries, these are the capillary beds, what's so-called the capillary beds or the capillary loop. And this is where this exchange of nutrients and oxygen for carbon dioxide and waste, this is where this exchange is actually happening. All right, so you will not see any exchange of nutrients or oxygen in the veins or in the arteries. It's happening exclusively in the capillary loops. All right. So I would like also to bring your attention to how the arteries and how the veins are structured. Or let's put it this way. You can see here in this diagram, and this is why I chose this picture. You can see the thickness of the artery, and you see that the arteries are very thick. They are very resilient, very strong, especially the arteries that are closer to the heart. The aorta, for example, aorta, which is the main artery of the body, is the thickest and the biggest and the strongest. And this is very good because it has to withstand a lot of blood pressure as it exits the heart and bring blood and pumps heart and bring the blood to the rest of the body. So the walls of the arteries are very, very thick, and they are made mostly of a thick layer of smooth muscles that you can see here that is surrounding the entire inner tube of the arteries. And these smooth muscles, what they do, they can contract and they can relax. When those smooth muscles contract, they restrict the amount of blood flow in the inner tube, and they restrict the blood flow, reduce the amount of blood that goes in more distant part of the artery, and they also increase the blood pressure because we are squeezing the fluid in a smaller diameter. So every time that the muscles contract, they constrict the blood flow, increase the blood pressure, and this is what we call vasoconstriction. On the other hand, when those muscles, big smooth muscles, when they relax, they allow the artery to dilate and they allow more blood to flow in the inner tube, in the arteries, and they reduce the blood pressure in the body. Okay, and this is what we call vasodilation. So vasodilation, when the arteries expand, allow more blood to flow in them and reduce the blood pressure. Vasoconstriction, when the arteries contract, when the smooth muscle contract, restrict the blood flow and increase the blood pressure in the system. All right, so these are the arteries, and as I said, they are the thickest when they are closest to the heart. But as we travel further away from the heart, we see that the arteries are branching several times into smaller and smaller arteries until they eventually branch into the arteriole, which is the small artery that connects the capillary to a larger artery. And from the arterioles, we see the branching into the numerous capillaries that comprise the capillary loop. When those capillaries join back together, they form a venule, which is a small vein that connects the capillary bed to the vein. And the venule, when several venules join together, they form a vein, and then the vein brings the blood back to the heart in a lower pressure. And there is low pressure in the veins when compared to the arteries. This is why, by the way, you see here that the veins are equipped with those unidirectional valves that allow the blood to flow in one direction, and they prevent backflow of blood into the vein. So we use those valves are very, very important for us because the blood pressure in the veins is lower than the blood pressure in the arteries. So we need this vein to help the blood flow in the right direction. And when those veins are compromised, we see backflow of blood into the veins, and this is what we call varicose veins. Okay, this is when varicose veins begin to develop, and they could be dangerous, and you do want to treat them if you have them because they can result in blood clots later. All right, and again, you see that also the veins are surrounded with those smooth muscles, not the same thick layer as the arteries, but they do have some smooth muscles around them that allows them to vasoconstrict and vasodilate. Okay, so this is the systemic view of the systemic circulation. We also have the pulmonary circulation, but this is the circulation between the heart and the lungs, but this is not for this presentation. What I do want to do now is to zoom into the capillary bundle, into capillary bed that you see here. So now we are moving to diagram number 2. All eyes on diagram number 2 now. And we see the arteries, we see the arteriole that is branching from the artery, and then from the arteriole, we see the numerous branching into the many capillaries that are forming, that are comprising the capillary bed. And what's important to mention here is that the exchange of oxygen and nutrients for waste and carbon dioxide doesn't happen simultaneously. It happens in a consecutive manner because there are differences in pressure inside the capillaries versus the pressure outside the capillaries. And I will explain. In the part of the capillaries that is closer to the arteriole, in the arterial end of the capillaries, the pressure inside the capillaries is greater than the pressure outside the capillaries. And this is what allows oxygen and nutrients and fluids to evade from the capillaries into the outer environment. When the capillaries are joined back together in the area that is closer to the venule, then the pressure outside of the capillaries is greater than the pressure inside of the capillaries, and this is what pushes all the waste and the carbon dioxide and excessive fluid back into the microcapillaries and then into the venule, eventually back into the veins. Okay, so there is a very delicate balance of pressure along this capillary bed, which dictates how well nutrients and oxygen and other molecules and fluids will be released to the tissue, and how well the waste will be reabsorbed in the capillary, in the system. Okay, so this is the capillary bed. By the way, when blood flows from the arteriole to the venule through all the capillaries, this is what we call microcirculation. And now what I want to do is to zoom in even further into one of these capillaries here that is part of the capillary loop. And this is diagram number 3. So all eyes now on picture number 3 here at the bottom. And now we see the capillary itself. And what we see first and foremost is that the capillary is very, very thin. Okay, it is very, very thin. It's about 8 micrometers in diameter, and the diameter of the red blood cells on average is 7.8 micrometers. So it can barely squeeze in the capillary, and it allows only one red blood cell to squeeze at a time. So they go one after the other, and this is what allows them to release the oxygen and bind back the carbon dioxide in the hemoglobin site. Okay, so they can barely squeeze in those red blood cells. Another thing that I want you to pay attention to is that the walls of the capillaries are also very, very thin. They are made of a single layer of endothelial cells. Endothelial cells, these are the cells that make the tubes of any blood vessel in the body, including arteries, including veins. You can see them here as the innermost part of the tube of arteries and veins. But unlike arteries and veins, capillaries don't have any muscles around them or any fibrotic tissues around them. This is just this endothelial lining that makes the capillaries, which is both a good news and a bad news. It's a good news because it allows all the fluids and the nutrients and the oxygen to evade from the capillaries much more easily than other types of blood vessels. And in addition to the fact that these walls are so thin, we also have those slits between adjacent endothelial cells on the walls of the capillary itself. We have those many slits that when the capillary expand, they also expand, and they allow bulk flow of nutrients and oxygen and other materials out of the capillary, and allow them to reabsorb all the waste much more effectively. Okay, so this is the good news. This is why the fact that those capillaries are so thin, this is why this is a good thing. However, it also means that those capillaries are very, very fragile. Okay, and they can experience damage much more easily when compared to arteries and to veins, because if you expand them and if you delay them and then you constrict them, delay and constrict, over time, the cells that make the endothelial cells will get weaker and weaker. The elasticity of the capillary will reduce, and we will start seeing those vascular damage that are forming. Okay, so keep that in mind. That keep in mind that the fact that the capillaries are so thin, this is very good for us because this is what allows this exchange of nutrients. But it also means that the capillaries are much more susceptible to mechanical damage, mechanical stretch and damage. All right, I think that enough said now about the systemic circulation of the body. Oh, what I failed to mention here, I took out of this presentation, and this is a very important component of the circulatory system. These are the the lymphatic capillaries, of course, the lymphatic capillaries that are not shown here in the diagrams, but they are intertwined all around the blood capillaries, and they help the system to retain fluids and to retain waste that are not reabsorbed by the capillaries themselves. So not all the fluids that are evading from the capillaries in the arterial end will be reabsorbed in the venule end, and for that reason we have the lymphatic drainage that removes these excessive fluids from the tissues. Okay, but we are not talking about the lymphatic system today. We're only focused on the blood capillaries and the veins and the arterioles and the arteries. All right, so this is in a nutshell how the circulatory system of the body works. And now that we understand how it works, we can have a more dedicated discussion about the vascularity of the skin and how the blood flows in the skin. and what is the skin vascular network, which you see here now on the screen. So we begin with the fact that the average human body holds approximately 5 liters of blood, give or take, of course. About 6% of which flows to the skin at any given time. And just for comparison, the brain gets approximately 14% of the total body flow at any minute. Okay, we measure it in milliliters per minute in terms of blood flow. So the skin gets approximately 300 milliliters of blood every minute that is circulating in the skin. And as you can see here in this diagram, the vascular network of the skin is divided into 2 horizontal plexuses. And these are the deep plexus and the superficial plexus. So the arteries that are feeding the skin, they come from deeper tissues, from the muscles. You can see them here at the very bottom of this diagram. And from there we have arteries that are branching upward, ascending arteries that go upwards toward the surface of the skin. When they reach the junction between the reticular dermis and the hypodermis and the adipose tissue, they branch to form the deep plexus. They branch horizontally to form the deep plexus that is responsible for feeding adipocytes and deeper structures of the skin, like the hair bulbs and all different types of glands, sweat glands and sebaceous glands. They are all fed by the deep plexus of the skin. From the deep plexus, we see that there is one more branching upward, ascending arteries that go upwards towards the surface of the skin. And when they reach the papillary dermis, they form the superficial plexus. They branch horizontally one more time to form the superficial plexus, approximately 1.5 millimeters under the surface of the skin. This is where we have this superficial plexus. Okay, and it's from this plexus that we will have these ascending capillary loops that go into the dermal papilla enclaves very, very close to the epidermis. So each and every one of these dermal papilla enclaves is fed by at least one capillary loop or capillary bed. And it's from these capillary loops that oxygen and nutrients will diffuse into the epidermis itself. And of course, that the epidermis does not contain any blood vessel. All the nutrients, all the oxygen that are feeding the keratinocytes and melanocytes and other cells of the epidermis are diffusing from those capillary bundles that are located in the dermal papilla. They will simply diffuse through the epidermal-dermal junction, which is very, very porous. Okay, so in addition to nutrient delivery and waste removal, the vascular network of the skin helps the body to regulate its temperature through vasoconstriction and vasodilation. Okay, and this is a very important mechanism of our body to allow it to help it control the core temperature of the body. If we are now jumping into a pool of ice water, we are very, very cold, we are close to hypothermia. The larger vessels under the skin will constrict and they will restrict the amount of blood that flows to the surface in order to keep more blood closer to the core of the body, to keep the core temperature of the body constant. On the other hand, if we are now, exercising and the body temperature increases, we will see that those larger vessels will dilate. We will see vasodilation in order to flow more blood towards the surface of the skin, towards the superficial plexus, where the heat will evaporate into the atmosphere much more easily. So this is how the body uses these vasoconstriction and vasodilation mechanisms in order to control the temperature of the body. Another thing that we need to keep in mind is that lesions that are forming in the vascular network of the skin at the level of the superficial plexus or above it, which means the superficial plexus and those capillary bundles, capillary loops, if the lesion is there, then it will likely to respond better to the IPL treatment, simply because deeper lesions that are forming in the deep plexus or even deeper than that, it's simply the energy will not penetrate. Oh, sorry, the energy will simply won't penetrate as deep. So all the lesions that we actually see on the skin, or most of the lesions that we see on the skin that are vascular lesions, luckily for us, they are happening in the superficial plexus or in these capillary beds that are feeding the epidermis. So in this case, where we can treat most of the vascular lesions that we see or we perceive as aesthetically unpleasant. Okay. Anything else that I want to say about the skin vascular network? I don't think so. I think this is it. Okay. So now that we have discussed the systemic blood circulation, and specifically the blood circulation in the skin with the deep plexus and the superficial plexus and the capillary loops that are feeding the epidermis, now we can start talk about what can go wrong and what are the main types of vascular anomalies that are forming in the superficial plexus and the capillary loops that we can treat with the 3D IPL technology. And generally speaking, we have three categories of such anomalies. We have anomalies or vascular disorders that are characterized with angiogenesis and endothelial hyperplasia, which means hyperproduction of capillaries and arterioles and venules. And these are usually lesions that are manifested as hemangiomas. Hemangiomas or cherry angiomas, those red moles that are forming above the surface of the skin. They are raised and they are, relatively speaking, they are easier to treat because they are simply there is more target that is clustered in a small area. So the hemangiomas usually responds very good to the treatment. So this is hemangiomas. The second category is of lesions that are characterized with dilation of arterioles, venules, and capillaries, and this is usually manifested as telangiectasia, or is in layman words what's so-called broken capillaries, spider veins, and so forth. Telangiectasia, abnormal dilation of the small blood vessels that are feeding the skin. And finally, the last category is of conditions that are characterized with chronic flare-ups, chronic inflammations, and flushes that could be associated with telangiectasia and acne-like breakouts. And this is what we call diffused redness or rosacea and couperose skin or erythrosis. All these conditions that are characterized with systemic flushing of the skin, of the face, periodic flushing, inflammation that could be associated, can express telangiectasia and also acne-like breakouts. These are the rosacea and the couperose skin that we can also treat with the IPL. So now what I want to do is to dive just a little bit deeper into each and every one of these conditions, just so we have a better understanding of the of how these lesions develop and how they behave. Okay. Just a moment, please. Okay. All right, so let's begin with hemangiomas. Hemangiomas that are also known as cherry angiomas. These are benign lesions that comprise mainly of small blood vessels above the skin level. They are raised lesions that are caused by local endothelial cell proliferation and hyperplasia of capillaries. For reasons that are still not fully understood, although there is a strong belief that there is a genetic component that is causing this kind of lesions to develop. But for some reasons, we see these local hyperplasia of capillaries. We see angiogenesis in a small area. And then we have a cluster of capillaries that is above the skin level. The diameter of these lesions can change between 0.1 millimeter to 10 millimeter in diameter. And the color can also change from red to purple. And these kind of lesions, they affect people of all ages, all genders, all ethnicities. They are more common with age, of course, although there is also, it's quite common to see it in newborns, what's so-called infantile hemangiomas. This is hemangiomas that are present at birth. And as I said, the cause of hemangiomas is not fully understood, is not known, but genetics is believed to be involved in this development of these lesions. And what we have to keep in mind, again, because the target is more concentrated and is above the skin level, it is relatively easier to treat hemangiomas when compared to other vascular conditions. And every time, or not every time, but I strongly recommend you, when you do treat hemangiomas, use the stencils that comes with the system, with the alpha, to expose only the hemangioma itself and protect the surrounding skin around it, because you see that this is a very well-defined lesion. The skin around it is relatively unaffected, and we don't want to waste energy on the healthy skin around the hemangioma. All right, so this is a few words about hemangiomas. Sorry. Next we have telangiectasia. It took me a while to learn how to say the word telangiectasia, but now I know. So telangiectasia, or as many people refer to as broken capillaries, spider veins, you name it, these are dilated blood vessels under the skin surface that create those famous visible patterns of lines that we can see here in all the different pictures. And this is the result of endothelial wall that is getting weaker and weaker over time until the point that it can no longer go back to its original diameter, to its original shape, and it remains dilated and basically compromise the blood flow in the area. It doesn't compromise it, but it's the blood flow in dilated capillaries is not as effective as blood flow in healthy capillaries because of the changes to the blood pressure in those dilated vessels that restrict the amount of nutrients and oxygen that can be delivered to the site. Okay, so think about it in terms of the pressure inside dilated vessels versus normal vessels. Okay, so over time, the endothelial wall gets weaker and loses its elasticity. The vessel remains open. Remains dilated. Sorry. There are three main patterns for telangiectasia. There is this linear pattern that we can see here in some areas, arborizing pattern that you can see here very clearly in the upper picture, and the famous spider pattern, that what people call the spider veins or the spider capillaries, that, well, looks like a spider. The telangiectasia colors can also change from reddish to bluish. When it's red, it indicates the dilated arteries or arterioles. And when it's bluish, this is an indication that the part of the vessel that is dilated, this is the venule part of the capillary bed, or even the vein, the small vein itself that is dilated. Now, there are multiple factors that may contribute to the development of telangiectasia, and this could include genetic or hereditary factors, people with genetic predisposition for telangiectasia. Usually when it's genetics, then it's formed here on the nostrils, on the connection between the nostrils and the upper lip. Another cause this is underlying conditions that can over time create or form those telangiectatic pattern, like rosacea and poikiloderma, scleroderma, all these conditions that cause the vessels to expand and shrink. Over time, they may also express telangiectasia. Let's see what else. Hypertension medication that dilate the blood vessels well, could cause telangiectasia because they are expanding the blood vessels. Topical steroid use has been shown to increase the number of broken capillaries or telangiectasia in the skin. Pregnancy, that is a mechanical stretch.
20 minutes.
20 minutes?
How we treat it.
Okay, I'll move more quickly. Okay, sorry. So there are many different reasons that can cause telangiectasia. These include hereditary and lifestyle conditions, and also underlying conditions. And lastly, we have rosacea, which is a diffuse pattern of redness. Rosacea or couperose skin. This is chronic inflammatory condition of the skin that affects many people, more than 3 million people in Canada and more than 20 million people in the States. So if you don't have rosacea, you probably know someone that does have it. This is a condition that usually affects the central part of the face, the cheeks, the nose, and the forehead and the chin, mainly the facial areas. Rosacea is common both in men and women. The onset of rosacea is usually between the age of 30 to 50, and the higher risk group is people with fair skin and Celtic background. These are risk factors that people of fair skin and Celtic background can usually develop rosacea more than other the darker skin tones. Okay, so this is a risk factor. Rosacea is caused and triggered by a combination of factors, again, including environmental factors, lifestyle, hereditary factors. A good example of this is Lady Diana, Princess of Wales, that has rosacea. Her husband, Prince Charles, also had rosacea, and whole and behold, both their children, William and Henry, both of them has rosacea. So this is definitely an hereditary condition. There are 4 subtypes of rosacea that we need to be familiar with. We have the erythematotelangiectatic rosacea that is characterized with chronic flare-ups and flushing of redness with telangiectasia, like what we see here in picture number A, in picture A. The second type is papulopustular rosacea, and this form of rosacea is marked by persistent redness and pimple-like bumps that are often mistaken for acne. The third type is rhinophemia, which is a very interesting case that affects mostly the nose. The skin of the nose gets thicker and it appears bumpy, and this is what, as you can see here, Mr. Bill Clinton is dealing with, the rhinophemia. And the last one is ocular rosacea that is affecting mostly the eye area. Now, one person can have only one type of rosacea throughout their lives, but other people can experience different types of rosacea, and they can have more than one type at any given flare-up. So if someone comes to you and they tell you, well, I know that I have rosacea, but every time, but so far it's only being the one that has telangiectasia in it, the type number A. Now what I see on my face is acne. They think that this is acne, like they have papulopustular eruptions. So just so you know, it's most likely not an acne, but the papulopustular type of rosacea that is now breaking out. Okay, so keep in mind that this could be some kind of mix and match between the different types. Now, rosacea can be tricky to treat. The treatment usually combines prescribed medications, rosacea-friendly skincare, and IPL to reduce the appearance of background redness and the telangiectasia. So what I'm trying to say is this: IPL will not cure rosacea. There is no cure for rosacea. This is a chronic condition that can be manageable. What the IPL is giving us is the ability to reduce the visibility of the flare-ups by targeting the veins, targeting the telangiectasia and the background redness. Every time there is a flare-up, it will be less visible and less socially awkward. So there is great benefits of using IPL to treat as part of the treatment for rosacea. Okay. Oh, I thought this one was on hide. I'm gonna skip port wine stains because this is other medical supervision only. And now what I want to do is to talk about how IPL works to clear vascular lesions from the skin, and I want to do it through the lenses of telangiectasia. Let's take it as a case study now. So let's say that we have telangiectasia and we are now want to remove it with the IPL. So how the treatment, how the process works? First and foremost, we need to understand that oxyhemoglobin is the target chromophore, not the melanin, of course. This is the oxyhemoglobin that is found in all these dilated vessels that you see here. So what you see here, this is a cross-section of the dilated vessels, and we have some normal undilated vessels around them. Now, when we release the pulse, the light energy is absorbed by the oxyhemoglobin and it is converted into heat. So the heat is generated within the red blood cells inside the dilated vessel and then transferred to the endothelial walls. And the purpose of the treatment is to damage the endothelial lining without damaging the surrounding tissue, of course. The purpose is to damage the walls of the vessels and not the red blood cells themselves. And this is what we are trying to achieve in this term of selective photothermolysis. Once we are ablating the dilated vessels, it will take a few weeks for the body to remove the debris, and eventually the dilated vessels will be cleared from the skin. And this is how it looks like, the illustration. So we are releasing the pulse. So this is the pulse release, during which the oxyhemoglobin absorbs the light and generates the heat that is transferred to the walls of the vessel. The vessel is ablated, and then over time it will simply be removed from the skin. And as you can see, what we are left with, these are the small vessels, the small capillaries that were not dilated because they didn't have enough target in them to generate sufficient heat to damage the walls. So this is why, and the last bullet point here is very important, this is why in order to obtain optimal results, it is essential to maintain adequate blood flow in the area and avoid vasoconstriction during the treatment. Okay, we want to keep the dilated vessels dilated and we want to keep good blood flow in those vessels in order to have enough target to generate enough heat to actually ablate the vessel. If the vessel is shrink, if it's constricted, there is not enough blood, we may have suboptimal results. And this is exactly why the 3D IPL technology has a very clear advantage here, because in addition for controlling the pulse duration and controlling the pulse energy, you can also control the tip temperature. You can control the contact temperature with the skin, which means that you can avoid vasoconstriction and you can keep adequate blood flow and allow you to achieve the correct balance between protecting the tissue and avoiding vasoconstriction. You can see here the differences in the reaction of the skin to the pulse, where the pulse remains the same, the pulse duration and the pulse energy. The only thing that is changing, this is the temperature of the tip. And you see the difference between 5 degrees contact cooling and 15 degrees contact cooling. And this is especially important when you are treating vascular lesions, to keep the tip as warm. I don't want to say warm, but keep it 15 centigrade if you can, to allow normal blood flow and to prevent vasoconstriction. And this will have a dramatic impact on the result of the treatment. All right. I hope that this is clear. I am moving forward now. And now we can start talk about the IPL handpieces that are most adequate for treatment of vascular lesions. And these are actually the same handpieces that we're using to treat pigmentary lesions. But here, well, let's start from the beginning. We have the 530s handpieces, the small one and the large one, that are mostly beneficial or useful for treating shallow superficial capillaries, as well as pigmentation. But these handpieces will be great for facial telangiectasia, which is usually more superficial, and hemangiomas, and they are more suitable for lighter skin tones because of the higher absorption that this wavelength has by melanin in the skin. Okay, so if you are mostly interested, or mostly what you're mostly treating, this is facial telangiectasia, then the 530 nanometer will be a good choice. However, if you are interested in treating both facial telangiectasia and telangiectasia on the legs for example, if you want to treat deeper lesions, or if you have more darker skin clientele, then the 590 nanometer will be our go-to handpiece because it can go deeper and it has somewhat better absorption by oxyhemoglobin and less absorption by melanin. So both of them, both the 590 and the 530 can treat vascular lesions. The 590 can treat both superficial and deep vascular lesions. The 530 will only treat the most superficial lesions that we have, mainly on the face. Okay, wonderful. I am moving forward now. All right, so what we see here, these are the treatment parameters for the treatment of diffused redness. People with rosacea, couperose skin, erythrosis. This is the parameters that we recommend you to use, and you can find them also in the quick reference guides that we provided you, the QRGs. What I do want to say here, let's see. You see here that the tip temperature, the default is 15 centigrades, unless you are treating skin type 4, and then you want to have a better protection to reduce the risk of post-inflammatory hyperpigmentation, then we do want to cool down the skin a little bit more. So we will keep the tip temperature at 10. But generally speaking, if you can, increase the tip temperature to 15 degrees. In terms of how you do the treatment and what are the intervals, so you would need approximately between 3 to 6 sessions that are spaced 4 to 6 weeks apart. What you do is the same as we do with diffused pigmentation. First, we do one pass all over the area. We keep 10% overlap between pulses, and then we release 1 or 2 more pulses on prominent vessels or areas with telangiectasia. Okay, so refer to these parameters when you are treating vascular diffuse redness. If you are treating isolated lesions like isolated telangiectasia or hemangiomas, so these are the default parameters for the 530 handpieces and the 590 handpiece. And again, you would need, well, it depends. If this is hemangioma, hemangiomas could be gone after only 1 treatment, but telangiectasia may require 3 to 6 sessions that again spaced 4 to 6 weeks apart. You release 1 pulse over the lesion, and you can use the stencil to protect the surrounding skin. You wait for lesion darkening. We are expecting to see, also when we treat for diffuse redness, areas that have prominent vessels, dilated vessels, we are expecting to see that those vessels are getting darker after 1 pulse. If they don't, then you wait a few minutes and then you simply repeat it 1 more time, and you can increase the joules in 1 or 2. You can increase by 1 or 2 joules per centimeter square. All right. So these are the parameters for telangiectasia and hemangiomas, and these were the parameters for rosacea and couperose skin. And you have those in your quick reference guides. All right, a few more treatment tips. Like in the case of pigmentary lesions, we want to reduce the risk of post-inflammatory hyperpigmentation in people with darker skin types. So we do recommend them to use hydrating and anti-melanogenic skincare at least 2 weeks before the first treatment. Before the first treatment, we also recommend to perform a test patch and wait 15 minutes just to, to make sure that the skin reacts as we expect it to react, and there are no adverse reactions. We want to make sure that the area that we're treating is hair-free. If the lesion is around the hairy area, then you want to shave it with a razor, because the more you reduce the amount of melanin, the more energy will go to the vessels, to the blood vessels, and not to the melanin of the hair or the skin. Okay, so make sure that the area is hair-free. When you use the Milo to measure the skin type, you do it on adjacent area to the lesions and not on the lesion itself, because then you will get the wrong readings. You want to make sure that you are measuring unpigmented skin or skin that doesn't have any vascular lesion on it. And we set the parameters for the treatment by using the manual option on the screen. You click on the manual option and you set up the parameters according to the charts that we just saw, according to the Milo reading, and you're good to go. In skin types 1, 2, and 3, set the tip temperatures to 15 degrees. And as I said, the lesion is expected to become darker after a pulse. And if the color does not change, increase the energy by 1 to 2 joules and repeat 1 more pulse. Okay, so practice that and you will get better results with your alpha. In terms of post-treatment, this is quite similar to the post-treatment regime after treating pigmentary lesions. The area immediately after, the area is expected to feel hot and become reddish, of course. If needed, apply cold compress and follow with a soothing cream. Sorry. If you can, avoid those cold compressors, okay? If you can, don't use those cold compressors unless it really feels like a very intensive burn, which it shouldn't. But if it does, then only then I suggest you to use those cold compress. But you can use any kind of lenitive cream, Aquaphor, for example. We also, of course, we recommend to use the Ready Medical after to alleviate the irritation and also to help the skin heal more effectively and more quickly. And if needed, apply high potency sunscreen and avoid sun exposure at all costs immediately after the treatment, as much as you can. Between sessions, avoid hot showers, saunas, swimming, intensive exercise for 48 hours. Avoid UV exposure throughout the entire course of the treatment, the entire course of the protocol. As much as you can, avoid sun exposure and keep using high potency sunscreen and keep using the same hydrating anti-melanogenic skincare, and do not touch the area until complete recovery. Okay, but these are general guidelines that I'm sure that you're all already familiar with. In terms of contraindications, this is pretty much the same list as we saw before when we talked about pigmentation. Here we also have varicose veins. If someone has varicose veins, you do not treat them with the IPL because this could indicate a more serious problem and we want to treat it with other means, not with IPL. So varicose veins are contraindication for the treatment. What else? This is it. Yes, we ran out of time, but we are just done. So thank you very much for listening. If there are any questions, now is the time to ask.
Thank you very much, Doron. Thank you very much. Doron, I don't know, did you mention the blue veins or the veins that look like blue on the skin?
If it's blue, then it's veins. If it's red, then this is arterioles usually.
But it's important to say that the blood is not blue, okay? In any way, shape, or form.
I can tell you exactly why the veins appear blue, and
yes.
we don't see but this is
this is a different session. This is a different session.
It requires some explanation about how we absorb the blue light and the fact that the blood in the vein is deoxygenated, so it absorbs more red light, and then less red light is bouncing back. Only the blue light is bouncing back, and this is why veins appear blue. Yes.
Okay, I just wanted to mention it because in any way, because I saw sometimes, you know, on the web, you see so many things that the blood is blue because this is a vein. The blood is not blue, okay?
The blood is always red.
There is no blue blood, okay? Even not
but
today.
Moshe, it's very important to mention in this regard that the blood, when it goes out of the left ventricle, it is bright red. It is very rosy blood, not rosy, but bright red. When it leaves the capillary loop and when it flows in the veins, it's also red, but it's much darker red.
Okay, so this is because of the content of the oxygen or the CO2, but it's important to say that no, humans do not have blue blood in any way, shape, or form. The color is deceiving, and it indicates that it's a little bit deeper. So I just wanted to mention this one. Yes. Thank you very much, Doron, for a great session. As always, you guys are welcome to contact us with any question that you may have. And of course, this session has been recorded and it will be posted on YouTube, and we'll send you the recording so you guys may go back and look at stuff that you want to refresh. Thank you very much, everybody.
Thank you.
Bye-bye.